It has been a life's work, Tim. I treated my first cardiogenic shock patient in January of 1984. We started our acute MI program at the University of Michigan in December of 1983, and then 6 weeks into it, we had the very first patient. I'll never forget it, a guy that was a blood pressure 70, cold, diaphoretic. We shot his coronaries. There's a mid-LAD occlusion, and I thought, crap, I'm going to kill this guy, and I'm going to kill the program. But we put a wire through. As soon as the wire went through, flow established, and he had collaterals to his right coronary, because right coronary was occluded too. His blood pressure went from 70 to 110. I thought, oh my God, this is like incredible. So I've been doing this, and I've seen, as Cal said, you can see sort of some near miraculous recoveries, and that's why I think that's really what drives us to do all of this. If we didn't really think we were, just like you've done with out-of-hospital cardiac arrest, I mean, the stuff is really remarkable. So we'll talk a little bit about how to support the ventricle and the right ventricle. If you take a look at the data, actually it's a very common problem. If you look at the shock trial and the shock registry, evidence of right ventricular dysfunction is very prevalent. There's almost 40% of the patients, more than half of the patients have some element of right ventricular dysfunction, and a substantial portion actually have right ventricular failure. Now, how do you define that? There are three ways of looking at it. Very simplistically, anybody that's got a high CVP, so even if they don't have frank numbers, there's lots of data showing that congestion, increase in CVP in shock patients is really a huge problem. Also, you can just take a look, is the wedge greater than the right atrial pressure? Usually the wedge is greater than the right atrial pressure. If the right atrial pressure is greater than the wedge, then think about that. And then the PAPI, which is it sounds very complicated, but it's a pretty simple formula. So if you take the pulmonary artery pressure, let's say it's 40/20, so the difference is 20, and then you take a right atrial pressure of 10. All right, so that PAPI is 2, and you can kind of do a very simple calculation. If it's less than 1, then it really suggests that you have right ventricular failure. So those are pretty simple numbers to look at, but you really want to hound and take a look at the pulmonary artery catheter measurements. And I would really re-emphasize what Cal said, that you really want to take a look at the right heart cath, and that's why I think our outcomes are improving, because we can more intelligently drive the process. When a patient is hypotensive, what's the cause? How can you fix it? And you really have to think of both the right and left ventricle in terms of a consideration in these shock patients. This is an article that actually one of our fellows, Terry Bowers, published in 1998, so 20 years ago. And this is a patient that comes in with a total occlusion of the right coronary. So if you have a patient that's coming in with an acute inferior infarction and the occlusion is proximal to the right ventricular branches, this is the anatomic subset for consideration of right ventricular infarction. This is a patient that I did that it was just astonishing. He had a bunch of branches, and we put a big stent in, and then look over here, all those side branches are gone. And he developed severe, profound shock. So really be conscious about these RV marginal branches when you're working, even on elective cases. Losing an RV marginal branch can really be catastrophic. So I think that's something that we really have to think about. Now, in this patient, what we also found is that if you successfully reperfuse these patients quickly, the shock goes away. And actually, if you take a look at the coronary care unit, we're not seeing a lot of patients sort of dwindling around with RV shock for a long time anymore, because I think we're opening up the vast majority of these proximal right coronary occlusions. If you look over time, echocardiographically, the right ventricle bulges in systole, but it's really very resilient. This is one patient that had RV infarction with successful reperfusion. Within an hour, the ventricle is starting to contract better, and then at a month, the ventricle is completely normal. So the right ventricle is very resilient to ischemia. So the good news is that even if you have profound shock and you can successfully reperfuse these patients, the RV dysfunction really goes away very, very quickly. If you take a look then at the patients in terms of the LV inferior wall and the right ventricular wall, the patients in the lower number is the right ventricular wall. 4 is bad, 0 is good. the right ventricle responds very quickly. Within an hour, the right ventricle really has improved in function, and then after about a month it becomes normal. The left ventricle actually takes a longer time to recover. So again, a very important observation that these patients may have profound RV shock, but if you successfully reperfuse them rapidly, they're going to recover very rapidly. However, if they don't reperfuse rapidly, so this is a patient, this is divided between successful and unsuccessful reperfusion, and in the patients that have unsuccessful reperfusion, they linger. The ventricle really is very poor in quality, and then at a month it actually comes back. So hang on with these patients, really try to support them, because over time they will tend to recover, and at the end of it you'll end up with relatively normal ventricular function. Support devices, we did the RP Impella. This was the data. Mark Anderson and I were the co-PIs for this trial. And what was really pretty dramatic is as soon as you put this RP device in, the cardiac index absolutely skyrockets and the venous pressure really drops. So this is an enormously powerful tool. And again, one of the most dramatic things you'll see in a patient with profound RV shock, as soon as you put in the right heart support, the cardiac output dramatically increases. What we found is as soon as the ventricle was implanted, as soon as the pump was implanted, there was a dramatic reduction in need for inotropes. One of the other key points that I want to make for you is that inotropic support, in particular Levofed, is lethal to these patients. Okay, just please remember that, because what's happening is that you have a failing right ventricle. An alpha agonist is going to cause profound pulmonary vascular constriction. And as soon as you cause the pulmonary vasculature to constrict, there's no more ability for the blood to go forward, and the patients develop this cycle of worsening blood pressure, worsening cardiac output. So be very, very careful about using alpha agonists in patients that have RV shock. There are other devices that are available, and again, I think that the cardiac assist device is a wonderful device. I think that's a fantastic tool. You can put it in from the IJ. You can also add an oxygenator to this if the patients have RV failure and hypoxemia. Then you can provide oxygenation. As Cal said, one of the advantages is to know this equipment. This is a wonderful device. You can actually, they've actually allowed people to have this implant in the IJ, and they can actually walk around and be ambulatory. So this is really one of the big advantages to use the cardiac assist device for assisting the right ventricle. And they have a variety of different tools. And again, I think I would urge you to go to to take a look at these devices, because you can do, there's a variety of options. You can do VA ECMO, you can do VV ECMO, you can support the right ventricle, you can do the Protect Duo with oxygenation and support the RV and oxygenate. So really dramatically effective tools that are going to be available. And I would conclude for you, again, going back to the algorithm that Cal suggested, with acute MI shock, take a look at the outputs and calculate the PAPI. If the patients really are not adequately supported, take a look at the right heart cath, and then if the right ventricle is involved, you can then add support, and we've used primarily RV support without putting the patients on ECMO, but ECMO also could be used if you don't have an RV support cannula available. But it's really important to understand the hemodynamics so you can properly manage these patients. Thank you very much.